Hi, I'm Dr. Richard Finn from the Division of Hematology Oncology at the Geffen School of Medicine at UCLA. Thank you for joining me today for this educational activity reviewing the role of cyclin-dependent kinase 4 and 6 inhibitors in the management of breast cancer. When we're talking about cyclin-dependent kinases, we're focusing on a target that plays a critical role in controlling cell division. If we step back and just think about the cell cycle, which we all learn about in our training, the cell cycle under normal conditions is very tightly controlled, is divided into several distinct phases, and the role and goal of each phase is to prepare for the next phase and ultimately mitosis and cell division. During each transition point from each phase to the next, there are key regulatory components and proteins and genes involved that regulate cell division so that daughter cells do not contain genetic errors. We know the four phases that exist are G1, S phase, G2, and then eventually mitosis. Cyclin-dependent kinases are a large family of serine-threonine kinases that play a role in regulating these transitions from one phase of the cell cycle to the next. As their name implies, they do not function by themselves, but interact with regulatory subunits called the cyclin proteins. Together, cyclins and their corresponding cyclin-dependent kinase function to regulate cell division. There are several known cyclin-dependent kinases and cyclins. In general, they play specific roles during specific parts of the cell cycle. In addition, specific cyclin-dependent kinases interact with specific cyclin proteins. For example, cyclin-dependent kinases 4 and 6, which play a key role in regulating their transition from G1 to S, typically associate with D-type cyclins. CDK2 proteins interact with the E and A-type, and again regulate cell cycle progression at various stages. There are also some cyclin-dependent kinases that function as transcription factors and not as catalytic enzymes. In breast cancer, alterations in the cyclin D CDK4/6 pathway have been described. Throughout the years of basic science, we've understood that amplification of cyclin D1 occurs in a subset of breast cancers. Overexpression also occurs. There can be alterations in CDK4, both amplification and overexpression. Ultimately, retinoblastoma or RB loss, the loss of the RB gene product, which is critical in regulating G1 to S. And ultimately, the target for CDK4/6 is lost in a subset of breast cancers. There can also be loss of negative regulators of the pathway, such as P16 and P27, which when lost, this pathway can become hyperactive. And then correlating all these genetic alterations with various clinical findings, such as response to antiestrogens, prognosis. In some studies, alterations appear to be favorable. In others, they are negative prognostic factors. But ultimately, in breast cancer, when we think of the various molecular subtypes of this disease, we know that breast cancer can be driven by growth factor signaling, which in some cases are peptide growth factors such as the HER2 and EGFR pathway, among others, or by steroid growth factors such as estrogen. And regardless of whether these breast cancers are driven by peptide growth factors or steroid growth factors, the common denominator is that these pathways feed into the cyclin D1 CDK4/6 pathway. On this slide, we see a diagram of how CDK4/6, cyclin D, and RB play a role in cell cycle progression. As you can see on the outside of the cell, there's various mitogenic factors, whether estrogen binding to the estrogen receptor or other peptide growth factors such as the HER family, driving increased expression of cyclin D1, which then interacts with cyclin-dependent kinases 4/6, CDK4/6. And together, cyclin D1 and CDK4/6 are responsible for adding phosphates or hyperphosphorylating the RB protein in the nucleus. Once RB is hyperphosphorylated, it releases the E2F transcription factor to allow preparation and transition into S phase. And this hyperphosphorylation of RB is a critical point in this G1S progression. There are various CDK4/6 inhibitors in development: palbociclib, ribociclib, previously known as LEE-011, or abemaciclib, the LY compound on the diagram, are all designed to block the CDK4/6 kinase, therefore to block hyperphosphorylation of RB and therefore induce a G1 arrest and prevent cell cycle progression. One of the first selective CDK4/6 inhibitors to go to clinical development is this compound, palbociclib. As you can see from its kinase profile, it is very selective for CDK4 and 6 with the low IC50s. This is different from early generation CDK inhibitors, which were very non-selective and had activity against a broad spectrum of cyclin-dependent kinases, and as a result did not function very well in the clinic. Critical to the development of any new drug in cancer medicine is to identify a patient population that we think is most likely to benefit. This slide demonstrates from some of the pivotal preclinical data that identified a role for CDK4/6 inhibitors in estrogen receptor positive breast cancer. As you can see along the x-axis, there's a large panel of breast cancer cell lines color-coded by their molecular subtype. Their sensitivity to palbociclib is on the y-axis, the lower number meaning the cell lines that are more sensitive. As you can see, the cell lines that were most sensitive to palbociclib represented the luminal ER-positive breast cancer subtypes, as well as some of the HER2-amplified cell lines, whereas those that were most resistant tended to be the non-luminal or ER-negative lines. This developed a hypothesis that perhaps if we were to move a drug like palbociclib or other CDK4/6 inhibitors into the clinic, we would focus on the ER-positive subgroup. As a pathway to clinical development, me and Dr. Slayman and other colleagues at UCLA looked preclinically at the role of palbociclib in combination with tamoxifen in vitro in several ER-positive cell lines. And as you can see, that there was a synergistic interaction between anti-estrogens and CDK4/6 inhibition in increasing the amount of cell cycle arrest and growth inhibition. This led to an open-label, randomized phase 2 study, the PALOMA-1 study, to really test the idea of whether or not this laboratory observation would hold up in the clinic. This study was designed in 2 parts. Both parts of the study enrolled women that were ER-positive, HER2-negative, postmenopausal with advanced breast cancer that were not treated for metastatic disease. They could have had treatment for adjuvant disease, but had not received therapy yet for their advanced disease, and were randomized between the combination of palbociclib and letrozole versus letrozole alone. Palbociclib was given 125 milligrams daily, 3 weeks on, 1 week off, and these cohorts were accrued sequentially, initially just based on ER-positive, HER2-negative, and then another cohort, ER-positive, HER2-negative, but also evaluating patients who have molecular alterations in the cyclin D1 pathway, such as cyclin D1 amplification or loss of P16, the negative regulator. The idea being is, could we select a finer group of patients other than ER-positive alone? The patients were well balanced for various prognostic factors. There was some slight imbalances, perhaps a little more visceral disease in the letrozole alone arm. However, I would like to point out that about half the patients in each arm were newly diagnosed or had never had prior systemic treatment in the adjuvant setting, but about a third of patients had prior hormonal treatment, such as tamoxifen or even aromatase inhibitors. This was a positive study. This was an open-label study, but there was a significant improvement in progression-free survival, the primary endpoint, with the addition of palbociclib to letrozole. Here you see the hazard ratio is 0.488 for progression-free survival, or approximately a 51% decrease in the risk of progression with the addition of palbociclib. Median PFS was improved by about 10 months, from about 10.2 months with letrozole alone to just over 20 months with the addition of palbociclib. Here on this forest plot, you can see that across many clinical important subgroups, there was a consistent benefit to the addition of palbociclib to letrozole. That includes cohorts 1 or 2, whether you use just ER-positive or had the additional markers of cyclin D1 and P16 loss. Both groups got a significant improvement in PFS. There's also a significant improvement whether they had visceral disease or bone-only disease, prior chemotherapy, prior anti-estrogen therapy, or prior systemic therapy. was also significant improvement for those patients who had de novo disease or those who had prior adjuvant chemotherapy or any adjuvant therapy. Secondary endpoints include response rate. There was a significant improvement in response rate. If we look at patients who had all randomized patients, not just those with measurable disease, the improvement in response was from 33% to 43%. If we look at those patients who just had measurable disease, the improvement was from 39% to 55%. So a consistent benefit in improving response, and arguably response rates of 55% with the combination of CDK4/6 inhibition and letrozole really rival any combination chemotherapy regimen. If you include the stable disease rate for more than 6 months of 32% in all patients, we're really approaching a disease control rate of 80% or higher. Certainly, we need to consider side effects when evaluating a new agent in cancer medicine. As we see on this slide, the side effect profile of the combination of palbociclib and letrozole, we see that the most common adverse event that was observed was leukopenia and neutropenia. This was an expected finding given the mechanism of action of a CDK4/6 inhibitor, that it would affect the bone marrow, which is proliferating. And in the dosing regimen, palbociclib was dosed 3 weeks on, 1 week off to allow for recovery and bone marrow recovery. Remarkably, even though we had neutropenia, there were no cases of febrile neutropenia seen. When we talk about grade 3 neutropenia, that is really an absolute neutrophil count of 500 to 1,000. And even though that happened with a high frequency, this was not complicated by serious infections and typically resolved on its own. Growth factors in general were not required for managing patients. Importantly, other significant side effects of chemotherapy were uncommon, such as complete alopecia, diarrhea, nausea, vomiting. Taken together, the combination had a very manageable side effect profile that balanced out the impressive results in improving progression-free survival. Based on these data, palbociclib was granted accelerated approval by the FDA on February 3rd for the indication studied in the PALOMA-1 clinical trial. That is to say, in combination with letrozole for the treatment of advanced postmenopausal breast cancer for women who are ER-positive, HER2-negative. Given that it was an accelerated approval, a confirmatory study was required. The PALOMA-2 study enrolled 666 women in a 2-to-1 fashion. It was double-blind, placebo-controlled, to letrozole plus palbociclib, 125 milligrams daily, 3 weeks on, 1 week off, versus letrozole and placebo. And again, selecting patients only for ER-positive, HER2-negative status, given the cyclin D1, P16 evaluation in PALOMA-1 did not add any benefit over ER-positive alone. The results of this study will be presented at the ASCO 2016 meeting. Last year, at the ASCO 2015 meeting, results of PALOMA-3 were presented. This was a study that evaluated palbociclib with fulvestrant versus placebo and fulvestrant. And unlike PALOMA-1 and PALOMA-2, enrolled patients who had endocrine resistance, they'd progressed either on a prior endocrine regimen or within 12 months of completing adjuvant therapy. These patients had to have had an aromatase inhibitor. Also, this study included patients who were premenopausal as long as they were on ovarian suppression. These are the baseline characteristics for the study, and as you can see, about 20% of patients in each arm were premenopausal or perimenopausal. What was reassuring from the PALOMA-3 study is that the side effect profile of palbociclib mimicked a smaller PALOMA-1 study. That is to say, the most common side effects were neutropenia and leukopenia, but again, there was no increase in the incidence of neutropenic fever as compared to fulvestrant alone. Again, these side effects were managed with dose delays or dose reductions. The primary endpoint of this study was progression-free survival, and again, there was significant improvement in PFS with the addition of palbociclib to fulvestrant, improving PFS from 3.8 months to 9.2 months. This correlated to a hazard ratio of 0.422 and was very statistically significant. If we look across patient subgroups, again, as seen in PALOMA-1, a consistent benefit with the addition of palbociclib to fulvestrant based on several important clinical criteria, essentially all of them showing a benefit with the addition of palbociclib. There was a quality of life assessment included in PALOMA-1, and importantly, despite having some increased side effects as compared to fulvestrant alone, there was an improvement in quality of life with the addition of palbociclib. There are several ongoing studies with palbociclib in breast cancer. Perhaps most important is the movement of palbociclib to the adjuvant setting. This study, the PALLAS study, is currently being conducted through the U.S. cooperative groups and will be evaluating palbociclib for 2 years plus standard endocrine therapy versus endocrine therapy alone to see if this improvement in PFS that we've seen in PALOMA-1 translates into a decrease in recurrence for early breast cancer. There are other CDK4/6 inhibitors in development. This compound, abemaciclib, it is a very potent inhibitor of CDK4/6, as you can see on this kinase profile. It's been evaluated in several single-arm studies. This study looked at a dose expansion cohort in patients with advanced breast cancer. Unlike palbociclib, abemaciclib is dosed daily without a break on a 28-day cycle. Abemaciclib showed impressive single-agent activity. Here on this waterfall plot, you can see a number of patients have had significant decreases in their tumor burden, as well as a number having prolonged stabilized disease. And as we saw from the preclinical data, the patients who are achieving this are those that are hormone receptor positive. As mentioned before, many of these responses were maintained for a long period of time, and again, this was in a cohort of patients who had several prior treatments. This slide shows the response data between the hormone receptor positive and hormone receptor negative patients. This study accrued all patients with metastatic breast cancer, but the observation was that it was the patients who were hormone receptor positive who had responses and prolonged stabilization of disease, supporting the idea that abemaciclib could play a role in ER-positive breast cancer. The side effect profile with abemaciclib is similar to palbociclib and other CDK4/6 inhibitors. There might be a suggestion that the incidence of leukopenia might be a little lower, whereas the incidence of GI toxicity might be a little higher. This will have to be further evaluated in larger studies. However, based on this impressive single-agent activity in patients with advanced breast cancer that's been heavily pretreated, abemaciclib was granted a breakthrough therapy designation by the FDA, and further action on that is awaited. Meanwhile, abemaciclib has moved into several phase 3 studies. The MONARCH 2 study is evaluating abemaciclib with fulvestrant versus fulvestrant alone in patients with advanced breast cancer that has prior treatment with antiestrogens. And the MONARCH 3 study looking at abemaciclib with a non-steroidal aromatase inhibitor versus placebo in a non-steroidal aromatase inhibitor. This study is very similar to the PALOMA-1 and PALOMA-2 studies. Ribociclib is the other CDK4/6 inhibitor that is in advanced development. Like the prior two compounds, very selective for CDK4/6 versus other CDKs or other kinases. Like the other compounds, this drug has demonstrated single-agent activity. Like palbociclib, it is dosed 3 weeks on, 1 week off to help manage the bone marrow suppression that is seen. It's being evaluated as a single agent as well as in combination with other novel agents. The MONALEESA program is evaluating ribociclib in various indications. MONALEESA-1 is a pre-surgical biomarker-driven study, whereas MONALEESA-2 and MONALEESA-3 are phase 3 randomized studies in combination with letrozole or fulvestrant, respectively, very similar to the path taken by palbociclib and abemaciclib. Finally, MONALEESA-7 is a phase 3 study in combination with antiestrogens. This appears to be the only study that is exclusively enrolling only premenopausal women. This is the schematic for MONALEESA-2, a 1-to-1 randomization of ribociclib, 3 weeks on, 1 week off, and letrozole versus letrozole and placebo, the primary endpoint being progression-free survival. Enrollment to this study is completed and results are awaited. MONALEESA-3, like the PALOMA-3 study, is evaluating ribociclib and fulvestrant versus fulvestrant and placebo. The primary endpoint for this study is progression-free survival. And finally, MONALEESA 7, looking at the premenopausal cohort with ribociclib, either with tamoxifen or an AI with ovarian suppression, or those agents with placebo. Again, progression-free survival is the primary endpoint. At the San Antonio Breast Cancer Symposium in 2015, there was data presented on ribociclib in combination with the PI3 kinase inhibitor alpelisib and letrozole. There is data to suggest that there could be synergistic interaction between blocking both the CDK4/6 pathway as well as the PI3 kinase pathway. This was a phase 1 study which evaluated a dose and supported the idea that perhaps a triplet combination could further delay and control ER-positive breast cancer rather than letrozole alone or letrozole and CDK inhibition. It's a very exciting idea, and we await further data. In addition, there was a study looking at ribociclib with everolimus and exemestane. As we know, everolimus and exemestane is an FDA-approved regimen for hormone-refractory ER-positive breast cancer. And here they evaluated the triplet combination and are evaluating various doses of everolimus in this phase 1 study to help manage side effects. Further data regarding efficacy is awaited as well. So we'll talk about some cases that represent potential indications for CDK4/6 inhibition in ER-positive breast cancer. The first case involves a 60-year-old woman who's postmenopausal, initially diagnosed with a stage 2 ER-positive HER2-negative breast cancer 3 years ago. This was found during routine healthcare maintenance. She underwent an evaluation and was found to have a well-differentiated tumor. She's treated with breast-conserving surgery, radiation, and then adjuvant letrozole. She's otherwise a healthy lady and active. She's been tolerating her letrozole without significant side effects. However, on a routine follow-up, she's noted to have some abnormalities in her liver enzymes. This refers her to a CT evaluation, and she's found to have a 3-centimeter mass on the liver. Biopsy confirms recurrence of her ER-positive HER2-negative breast cancer. This time, we'll consider various treatment options. They include chemotherapy, exemestane, everolimus, and exemestane, fulvestrant alone, or fulvestrant and palbociclib. Certainly, there's data to support all of these options. However, based on the PALOMA-3 data, fulvestrant and palbociclib provides a significant improvement in PFS versus fulvestrant alone. This is a patient who is progressing while on letrozole, a non-steroidal aromatase inhibitor, and therefore drugs like letrozole or anastrozole are less likely to be active. The patient does have visceral disease, however, does not appear to be at risk for immediate death from her tumor, and therefore an endocrine-based approach is reasonable. Certainly chemotherapy has activity here. However, in an effort to delay the toxicity of chemotherapy, an endocrine-based approach is very appropriate. And we know that fulvestrant plus palbociclib provides a significant improvement in PFS. So case 2 is a 54-year-old woman who presents to her doctor complaining of bone pain. During her evaluation, she's noted to have a right-sided breast mass, elevated alkaline phosphatase. Biopsy is performed, and pathology is consistent with an ER-positive HER2-negative breast cancer. Staging studies reveal her to have bone-only disease, but no visceral involvement. She's started on bisphosphonate, as well as palbociclib, 125 milligrams daily, 3 weeks on, 1 week off, and letrozole. Certainly, other options would include letrozole alone or chemotherapy. However, she has newly diagnosed metastatic breast cancer, and we saw that the addition of palbociclib to letrozole provided a 10-month improvement in PFS over letrozole alone. And in fact, for patients with bone-only disease, this was even greater. She comes in on cycle 1, day 14, as recommended in the FDA label for the first 2 cycles to have her white count closely monitored. And her labs are generally normal, except for a white blood cell count of 2,000, and her ANC is 1,200. While her ANC has fallen, this is still grade 2, and no further adjustments in dose are required. She returns 2 weeks later for cycle 2, day 1. At this time, she finished her 1 week off of palbociclib, and today her white count is 1,800 with an ANC of 800. Her ANC is less than 1,000, and per the guidelines in the label for palbociclib and as was performed in the clinical studies, patients did not start their second cycle or their next cycle of palbociclib until their absolute neutrophil count was at least 1,000. She continues on letrozole but holds the palbociclib. She returns a few days later and her white count is now 1,800 and her ANC is 1,100. She resumes palbociclib because her absolute neutrophil count is greater than 1,000 on a 3-week on, 1 week off schedule. She continues to have her CBC checked on day 1 of each cycle. After 3 months on treatment, staging studies show that she has stable disease on imaging and her breast mass is smaller on exam, and she continues on treatment. Should her white count, absolute neutrophil count specifically, be less than 1,000 on any day 1, then it is recommended that her dose be held until her white count recovers. Dose reduction should be held only for patients who have febrile neutropenic or other serious non-hematologic toxicity or prolonged delays in recovering her white count. We are just scratching the surface with the role of CDK inhibitors in breast cancer. There's a lot of unanswered questions. There are ongoing randomized studies evaluating CDK4/6 inhibitors in the various indications of advanced breast cancer, as well as with various anti-estrogen combinations. Ultimately, we're excited to see if the introduction of CDK inhibitors in early breast cancers increases the cure rate for this disease. Preclinical data suggests there's a role for CDK inhibition in HER2-amplified breast cancer, and ongoing studies of CDK inhibitors in combination with HER2-directed therapy are ongoing. The mechanisms of acquired resistance to CDK4/6 inhibition are still largely unknown. These will have to be elucidated so we have a better understanding of how to manage patients once they progress on a CDK4/6 inhibitor. In addition, while the first approval for these drugs is in breast cancer, I think there's a lot of excitement to see how CDK4/6 inhibitors will play a role in other malignancies as well as other types of breast cancer. Thank you very much for your attention. I hope you found this program useful in understanding the preclinical and clinical development of cyclin-dependent kinase 4/6 inhibitors in breast cancer.